A very, very good evening to all of you. And as you know that today we have a combined webinar with ESICM, ISCCM joined together. And we have two very, very eminent faculty with us, Professor Eli Ezzoli and Professor Victoria Metaxa, as an international faculty from ESICM. And also we have Dr. Subramaniam Swaminathan and Dr. Subhash Todi from India. Along with them, we have our President-elect, Dr. Srinivas on board, and Dr. Bharat Jigyasi is also there. So I welcome all of you, and I welcome all the participating delegates who are there on board to listen to this important webinar. And we have kept this webinar actually to see the problems which we are currently facing in our ICU, because number of patients, immunocompromised patients, are increasing day by day. So this is a very, very important webinar, what I understand. And to start with, I hand over the mic to Dr. Subhash Todi. Sir, please.
Thank you. Thank you, Dr. Pradeep. As Dr. Pradeep mentioned, the immunocompromised, many of the ICU patients, almost the studies have shown 1/3 of the ICU patients have immunocompromised conditions. So we are going to discuss about this during this webinar. We are fortunate to have two eminent international faculty and one national faculty. Professor Eli Ezzoli, he wears many hats, and he's a professor of medicine, critical care, intensive care in the St. Louis Hospital. He's the medical director of the medical ICU at the St. Louis Hospital, past chief of ESICM, past president of ESICM. And so he's going to deliver a talk on 15 minutes on an approach which he has devised and has published recently on immunocompromised host. And then we have Victoria Metaxa. She's a critical care and major trauma consultant from King's College Hospital, London, a very well-known hospital. She is the medical lead for the critical care outreach team, as well as end-of-life ICU lead. And she is currently undertaking an MSc in medical ethics and palliative care. And our local national faculty is Dr. Subramanian Swaminathan, known to many of you. He is an American Board of Infectious Disease, and he's Director of Infectious Disease and Infection Control at GGSC Chennai. And he's a Program Director of GGSC Chennai Chair, Transplant ID Subcommittee SIDS. So welcome you to all the three of our faculty. So we'll start with the basics. Empirical therapy, while giving empirical therapy, we just have the patient in front of us with history and clinical presentation. Based on that, we have to take a call. So to start with, we'll ask Dr. Shubra for 15 minutes presentation, role of history taking and clinical examination and clinical presentation in how to approach an immunocompromised patient so far as the antimicrobials are concerned. Subra, over to you.
Good afternoon, good evening, everyone, and good afternoon to our friends from Europe. Let me see if it's full screen. Please let me know if it's full screen for everybody. So I'm going to talk for the next 15 minutes, maybe 10 minutes, about how, as an ID guy, we come up with plans to go about the history examination and try and put it together in terms of syndromes to approach a patient who's immunosuppressed and lands up with a respiratory failure. My disclosures. So I'll start off with a case, not necessarily completely relevant, but there's a point here, I promise you. This was a patient from 10 years ago who had come to our Hyderabad center 3 years post liver transplant, was apparently doing very well post transplant, and was on minimal immunosuppression. And he developed this. There was a small lesion on the nose. And the question was, what was it? So at this point, even before they had sent this to me, they had, somebody had seen him and sent him on Augmentin for 5 days. And 5 days later, he looked a lot worse. And what I'm not showing you is that his eyes were also red and he had other symptoms as well. So the question is, what happened here? How do we approach this? Before we start therapy obviously needs to be started. The first question is, what is the diagnosis? The second question is, what is the therapy? And the third question is, how did this happen? So obviously start off by reading a few books, calling a few experts, try and figure out what it is. The way we look at it is we always start with the current symptoms. What are the actual symptoms other than respiratory failure? The most common symptoms that we see in a pulmonary issue is going to be cough, sputum, and fever. So I think all of these separately need to be handled, and all of these are very important. The questions here can really guide you in terms of what the empiric therapy should be, and also to help you decide what kind of tests to send off. Too often we are tempted to send off everything under the sun. You get a lab master and they start take, and you stop when probably the ink runs out in your pen. Always ask for other symptoms involving other organ systems. Start off with how long is the duration of symptoms. There are patients who present within a couple of hours. There are patients who present over days, and there are patients who present over weeks. The differential immediately changes depending on the onset and how long it's been. And that's where this concept of tempo comes in. And it's important to assess the tempo of the illness because of two reasons. One, if it is something which is slow moving, it is a more indolent infection or an indolent condition, need not be an infection, an indolent infection or a condition, and therefore you're not thinking of acute bacterial pathogens. You're thinking of less common problems and more atypical situations and things like that. And the second thing is, you have a little bit of time to assess these patients, and it's not necessarily that you need to react immediately to try and do something. And I think both of these are very, very important. Very often we don't ask this question about preventive options in terms of vaccination and or prophylaxis. Vaccination is often forgotten. A flu vaccine can absolutely do wonders for a immunosuppressed patient, whether it's transplant, non-transplant, whatever it is. Unfortunately, it's an opportunity often missed. And prophylaxis. So the common prophylaxis which may be used in different settings could be cotrimoxazole, acyclovir, valganciclovir, for antifungal prophylaxis. There are lots of different prophylaxis can be used in different kinds of situations. The commonest probably is cotrimoxazole, which is used in high-dose steroids, in patients who are significantly immunosuppressed post-transplant, and certain other designer drugs as well, where the pneumocystis or other infection risks are very high. And the problem with that is that being on prophylaxis does not exclude the possibility of a disease. And B, a question that often is missed being asked is, are you compliant with these drugs? Very often we just say, oh, the patient is being given these drugs, and we tick it off in our mind saying, yes, the drug must be in the patient. Like Dr. Everett Koop, the Surgeon General, said, medicines don't work if patients don't take them. Always ask about sick contacts. That's useful because if you're thinking of viral respiratory tract infection, very often there are sick contacts at home. Because if you have an influenza situation, you're going to have more than one patient in the same household having a upper respiratory illnesses. Although your patient with the index patient with severe immunocompromised is going to be more likely to be the sickest one in the ICU. But it's good to know that there are other contacts as well, because you're less likely to be thinking of bacterial infections and things like that. Although there are certain bacterial infections which are present like that. Always ask about unusual exposures, and that's key, because very often we have our patients getting a little adventurous. And like Dr. Prodi said, we have more and more patients going on very difficult kind of immune suppression regimens, and they are also a little more outgoing and they want to enjoy life. Good for them. But also they don't understand necessarily the risks involved in it, and they may not do a risk estimation when they engage in any particular behavior. So the next part is the immune suppression, and this is critical. So first question is, what is the primary diagnosis? Why is the patient on immunosuppression? So if it's a transplant recipient, what was the pre-transplant diagnosis? Has there been a problem post-transplant? And if it is a rheumatological condition, what is the primary diagnosis? What all therapy has been given so far? What is the net state of immunosuppression? What is the amount of drugs that the person is on? Unfortunately, this is a more difficult number to quantify because there's no single number you can lay your hat on. Very often we look at it in terms of how many different immunosuppressive drugs they are on, and we also look at the amount of steroid that they're getting. Unfortunately, it is very different person to person, and you don't have the same amount of immunosuppression for two different patients for the same amount of drugs. And therefore, it's an interaction between the drugs and the host immune system. And that's something which is quite difficult to predict. And some of it comes through touchy-feely experience over years of experience. Specific immune suppressants, because now we have more and more designer drugs. Like, for example, if you're using ibrutinib, we are seeing lots and lots of fungal infection in those kind of patients. If you're using eculizumab, you're more likely to see meningococcal sepsis over there. And also, very simply put, the most common immunosuppressant that we use is steroids. And the dose of steroid is very, very key. We know that if you're using more than 20 to 30 milligrams of prednisone for a significant period of time, at least 2 to 3 weeks, then your pneumocystis risk starts kicking in. So it's important to know what is the dose of it, because many of these things are kind of dose dependent. And the time of onset since immunosuppression, how long has the patient been on immunosuppression? Sometimes it's a very clear answer. Like, for example, if somebody is undergoing a stem cell transplant or a solid organ transplant, the date of the transplant itself becomes the date of onset of immune suppression for the most part. But again, it's important to notice that, some patients may have had immunosuppression even before that. Think of it as a, let's say, interstitial inflammatory nephritis for which the patient was on steroids and mycophenolate pre-transplant. So the immunosuppression may predate the transplant as well. So that kind of messes up with the schedule. And this is the even bigger problem. Very often, the immunosuppression is augmented because of new onset problems. In a stem cell transplant recipient, you may have a GVHD situation, or in a solid organ transplant, you may have a immunosuppression for rejection. And when you augment immunosuppression, you kind of reset the biological clock. Remember, the surgery has got nothing to do with it. Well, surgery has a little bit to do with it. What really increased the risk of infections in significantly immunocompromised patients is the use of medications, and the quantum and the amount of medication obviously makes a difference. So if there is recent augmentation of immunosuppression, and even especially if somebody is forgotten to restart, say, cotrimoxazole prophylaxis, then clearly these patients are very, very high risk. So in fact, one of the major reasons why we see late pneumocystis is because of augmentation of immunosuppression, and somebody has forgotten to add the cotrimoxazole prophylaxis. And also the time since the last dose. Why am I saying that? Now we are using more and more drugs with very long half-life. So, for example, alemtuzumab. We ID guys love calling it AIDS in a bottle because it gives you all the fun of AIDS without actually any of the fun of having acquired the disease. And this is something which can look like a HIV infected patient. And the problem is, if you're using prophylaxis for that, you can't stop the prophylaxis immediately after the last dose is done. It tends to stick in your body for a significant period of time. And if the patient thinks, oh, this is the last dose, I don't need it, then the patient is actually very, very vulnerable. And they need to be educated that the immunosuppression is still hanging in there and they need the prophylaxis, which they may not otherwise understand. So when we start with a history, we always ask about prior medical issues and infectious issues, because sometimes things have a way of coming back and haunting you. Relapses of certain infections are very, very common. Occupational history, because you want to know about high risk exposures to certain things, like are they handling animals, are they in agriculture, are they in in a healthcare setting, because very often we are seeing doctors and nurses coming through with absolutely horrible kind of immunosuppression due to cancers or transplant. Personal history, what do they do, what are their hobbies, what is their source of entertainment. Sexual history, our patients are living longer post-transplant and post-immunosuppression. And they're also vulnerable to all kinds of other problems, including sexually transmitted issues. Our patients are more agile and they're willing to travel everywhere, explore the world. And very often the problem is they don't always come back and talk to us about what are the safety precautions they need to take if they're traveling. And that's a bit of a problem, because, when they come back with a problem, you're left scratching and thinking, oh my God, I could have prevented this. So when you examine, you start off with the vitals. Keep in mind that it's important to look at the skin and mucous membranes, including the eyes and the mouth. It's worthwhile looking at it, even if the patient doesn't complain about it. Sometimes, a patient may be knocked out and you may not have a patient expressing anything, but it's important to look in there very, very carefully. Neurological findings. Why? Because there are a lot of infections in the respiratory system which tend to love going to the brain. Fungal infections, nocardia, quite a few of them. They love going to the brain, so it's important to keep those in mind. Yes, it's important to do a thorough other system examination. Examine the abdomen, joints, look for nodes, look for all the other things that you would normally do for a competent examination. I'm almost done, sir. So when you look at it in terms of syndromes, if you have a fever with rigors, cough, and lots of productive sputum going on for a short duration, you're thinking of a bacterial kind of a lower respiratory tract infection. If you have a short duration fever, non-productive cough, and rapidly progressing respiratory fever failure, you think of atypical pathogens like Legionella, Mycoplasma, Chlamydia, and definitely viral. But if you have a moderate duration symptoms with non-specific symptoms and maybe some hemoptysis, you're thinking of mycobacteria, fungi, nocardia, fusarium, all kinds of weird stuff. All of this is dependent on a lot of other risk attributes as well. But keep in mind there are non-infectious mimics which can sometimes confuse the pot. Pulmonary embolism can very often present in these patients, especially if they are not very mobile. Cardiac and renal disease, because many of these drugs are pretty nephrotoxic, they can end up with renal failure without even them knowing this, and they are getting older, they are at increased risk of accelerated atherosclerosis, they may be in cardiac failure and they may not know about it. Patients with liver disease can have portopulmonary hypertension, hepatopulmonary syndrome, which can mimic pulmonary conditions and can present with respiratory failure as well. Drug toxicity is often something that's missed, and we need to keep that in mind. Amiodarone does horrible things to your lung. So it's important to keep a look at the drugs and see if any of them is causing trouble. Other non-infectious conditions like lymphocytic interstitial pneumonitis, lung GVHD, and things like that. I'm not even going to go into a full list of that. And finally, malignancies. Lung malignancies, including lymphomas, can happen. EBV-related PTLD lymphoma and all that stuff. So the differential is extremely varied, and it requires a multidisciplinary approach to kind of get to ideas to what is to be done. But the empiric therapy should always be based on the syndrome that you decide on first, and then proceed with further evaluation. And with this, I will stop for now.
Thank you. Thank you, Dr. Subra, for this very practical overview and approach to this problem. It looks like there is so much to keep in mind while we are approaching an immunocompromised patient. One needs probably a checklist kind of a thing when you approach them, and go systematically, otherwise we'll miss things. One request to the audience and the participants, please do start writing questions in the chat box. We'll have half an hour for discussions at the end of the 3 presentation, and we'll welcome any questions pertaining to today's seminar, which is judicious use of antimicrobials in immunocompromised. Thank you, Subra, once again. So now I would like to welcome Dr. Victoria Metaxa. Once we have taken the history, gone through the physical examination, we send some routine tests, but when we are dealing with infections in the immunocompromised, the role of biomarkers becomes important. So I will request Dr. Victoria to present her case. Victoria, please.
Can you hear me?
Yeah.
Perfect. All right. So I'm going to talk to you about biomarkers that I fully understand it's not a very exciting topic, but I hope by the end of these 15 minutes, we will be able to understand the role of biomarkers in the immunocompromised, but also a little bit in general in our patients in intensive care. So what are we talking about when we talk about biomarkers? So biomarker is basically every measurable indicator of biological status that exists in our baseline, but also exists in pathogenic processes. So, and we use biomarkers all the time. We use troponin, BMP in cardiac cases. We use lactate a lot in intensive care, but also more specific biomarkers when we're talking about infections. And these are the biomarkers that I will specifically be talking about. So why is this so important? Why is it important to know about biomarkers and use biomarkers? Well, I think we've discussed this in the introduction. About 30% of all ICU admissions, when we're talking about cancer and immunocompromised patients, they are because of infection. And, I'm fully aware that not all cancer patients are immunocompromised. However, we see that almost 1 in 3 will have some bacterial form of infection. Those that are admitted into ITU for influenza, 10% are immunocompromised. And when we use box standard tests like blood cultures, they have very low yield. You see in the slide about 5 to 15% to actually diagnose and isolate what's going on for patients that are admitted with some form of community-acquired pneumonia. It is very important to say here that when we say immunocompromised, we mean your standard immunocompromised patient that either has a tumor, is receiving chemotherapy, has had stem cell transplant. But let's not forget that quite a significant percentage of our ICU patients that are not your standard immunocompromised, but are septic, will be immunosuppressed just because they are in ICU and just because they have sepsis. So just think broadly when you think about immunosuppression. Another thing that I would like to highlight here is that we tend to think that, when you are immunosuppressed, then your outcomes might be worse. Well, evidence doesn't really support that. So immunosuppression, there is no real evidence that immunosuppression affects the severity of sepsis, and there's conflicting evidence that immunosuppression alone is associated with a worse outcome. And that's just to bear in mind. That does not mean that it's not very, very serious when it happens. So this is a very interesting slide. This is a very, very nice narrative review by Pedro Povoa and co-workers. And you see on the left side of the slide, the three vectors that characterize sepsis normally. So basically you have your signs of infection, and bear in mind that in immunocompromised patients, the signs of infection might be unspecific, mainly because these patients don't have a robust immune system to talk about. There is microbiologic documentation, and that's your golden standard for diagnosing sepsis. And also you have your late and your late state, which is your organ dysfunction, where sepsis actually causes organ dysfunction. So when you use biomarkers, it's nice to associate them with these three vectors. So you have biomarkers that depend on the host response, and this is the classical C-reactive protein, CRP, and your procalcitonin, your PCT. Then you have biomarkers that are specific to the pathogen, and that's beta-D-glucan and galactomannan, the two that we normally use. And then, of course, there are biomarkers that really characterize the organ damage. And creatinine, for example, for kidney injury is the most basic one that almost all of us use, or the newer renal biomarkers. So this is the slide that if you fall asleep after this, it doesn't matter. This is the slide that's really important to pay attention to. So biomarkers can be categorized in three categories. So they are prognostic, predictive, and theranostic. So when we talk about prognostic, it means that this biomarker can prognosticate the outcome of sepsis. So the patient has sepsis, but the question is, does a CRP of, 250 almost always predict that this particular patient will die from sepsis in ICU? And I hope you agree with me that such biomarker doesn't really exist. It is very important to collect standard and non-standard biomarkers as part of clinical trials because they help in phenotyping, but biomarkers are not very good in prognosticating. Biomarkers are not very good in theranostics as well. That word is a composite from diagnostics and therapy, which basically means that you have a biomarker that for a specific patient is used to diagnose, but is also used to see whether therapy works. So we're talking about precision medicine. And although it's nice, it's a bit of science fiction and it's not really bedside. So all the biomarkers that we are using, and I'm going to talk about further more and more, are predictive biomarkers. And predictive biomarkers are those that when you, as a clinician, have a suspicion that the patient does have sepsis, so you have a pre-test probability that is positive, then the biomarker comes and helps you, a post-test probability, and adds valuable information for you to actually diagnose and also see whether the therapy actually works. And for a biomarker to be useful, it needs to decline or return to baseline when you give someone successful therapy. And it shouldn't really be exhausted or get fatigued. So when you get another infection and another infection, the biomarker needs to increase and decrease accordingly. And I will show you why I think this is very important. And just as I said, fall asleep after this if you want to. I just want you to know that biomarkers alone cannot be expected to become these magic bullets that allow you to diagnose and treat patients. This slide is very busy. I just put it down there to just tell you that there are about 250 potential biomarkers that are being studied. The whole idea is that they are able to somehow differentiate between this systemic inflammatory response syndrome that our patients might get because they have a harmful stressor. So for example, because they have an infection, because they have trauma, because they have a cancer and they've underwent surgery. So this is an inflammation, but biomarkers need to distinguish between that and between this infection-triggered organ dysfunction, which is basically sepsis. And you see here that they are again, the classification between pathogen-associated molecular patterns and damage-associated molecular patterns. So basically a whole host of biomarkers. But are they useful? Well, they're not useful for your basic ICU patient, and they're even less useful when we're talking about immunocompromised patients because they're so difficult to interpret. And I'll tell you a little bit later on, because these patients will definitely have infections. They have, as the name says, they don't have a very robust immune system, but they will always also have non-infectious conditions that will affect the biomarkers. So for example, an inflammation of the mucosa, whatever mucosa that is, they will have bone marrow suppression post-chemotherapy, they might have graft versus host disease, and the tumor itself, if we're talking about cancer patients, might influence the biomarker expression. So let's talk a little bit about the host response biomarkers. So your usual ones are your CRP and the procalcitonin. Let's talk about CRP. So this is an acute phase. It's an acute phase protein. It's synthesized almost isolatedly in the liver, and it is increased in response to cytokines, more predictably IL-6. So you see on the slide, it's increasing in about 4 to 6 hours, so quite early. It reaches more than 2 days almost to get its peak, so that is less useful. And although it doesn't really, immunosuppression doesn't really have an effect on CRP, when you see the second hit decreases its effectivity, so it reduces its increase by about 70%. So remember when we said a biomarker needs to respond and not get fatigued, it appears like CRP does get fatigued. So that is a problem. And you'll see that this was quite a large prospective observational study that included about 200 ICUs and about 50 biomarkers. And it did see and proven that biomarkers, all of them, all 50 of them, are quite average in distinguishing between inflammatory response and infection. But of all this average landscape, CRP was okay and was at least as good as using no biomarker or a combination of biomarkers. So it's not excellent, it's average, and it doesn't really distinguish between viral or bacterial infections. What works though, which is very, very good to know, and it was a surprise to me as well, is that what we need to target, of course, is not one value of CRP, but the relative CRP variations. So if we look at the CRP at day 0 and compare the CRP after intervention, so after antibiotics, after more antibiotics, it's the ratio that is more informative than the actual absolute CRP change. And if that's not enough, if we're talking about immunocompromised patients, CRP becomes even less specific. It becomes even less specific because it may increase in non-sepsis or respiratory or other conditions. So it might increase in excessive and metastatic cancers after invasive procedures. Radiation might increase it, medications might increase it, and completely oppositely, we know now after COVID that tocilizumab, which is something that, for example, patients with CAR T therapy may receive, renders CRP completely useless because then it will never rise again for weeks at an end. This is a slide that basically shows you that CRP is not just an effective biomarker. So this is a very nice systematic review that shows that CRP, you can use CRP for prognosis of tumor recurrence. And you see, especially in gastrointestinal tumors and renal tumors. So, you have an increased CRP on a cancer immunosuppressed patient. You don't know why it is increasing. So not really useful. But what about procalcitonin? So procalcitonin is a prohormone. It is the most studied biomarker in the setting of ventilator-associated pneumonia. It rises quicker than CRP. It reaches its peak concentration quicker, so that's good. But then you see immunosuppression gives you frequently false negatives. It also is quite poor in distinguishing between viral and bacterial infections. And then if that's not enough, let me tell you that there are at least 18 randomized control trials that look at procalcitonin as a marker for guiding antibiotic users. And they all conclude that PCT-guided antibiotic use, even in immunocompromised patients, it's quite safe. So you can decrease your antibiotics or stop them guided by PCT, and mortality doesn't increase. However, those RCTs all have great caveats that we should be aware of. So all of them use protracted courses of antibiotics, which is not something we do normally. And some of them, the majority of them, had up to 35% of patients excluded. So the Pronata study that was in compromised patients basically excluded patients that had a bone marrow transplant. So not very useful. So yes, you can use procalcitonin, but is it very useful? These are, as you see, other negative points about procalcitonin. You can't really, we haven't really agreed what procalcitonin, which cutoff point is the one that will tell you that you've got sepsis. And as we said, you can't really distinguish between a viral for a bacterial infection for community-acquired pneumonias. And again, and even more in the immunocompromised, it has a limited predictive value because other conditions increase it. So, you know, thyroid carcinomas increase it, lung cancer increases, carcinoma of the liver. And then, although it is higher in hematological malignancies, it can also rise in solid tumors. It can distinguish between gram-negative sepsis, gram-positive sepsis. So yes, it is safe and we use it, but whether 100% it's dependable, it doesn't really appear so. And what about pathogen-specific biomarkers, beta-glucan and galactomannan? You can see them here compared head-to-head. So BDG is derived from the fungal cell walls, and for that, it's considered to be like a pan-fungal serum biomarker. It has a high negative predictive value from PCP pneumonia. So if that is not raised, you hardly ever have PCP pneumonia in your immunocompromised patient. And then repeating it, its sensitivity can increase. Galactomannan, on the other hand, is more it's more specific for the Aspergillus species. It's very specific for the diagnosis of invasive pulmonary aspergillosis, and maybe in combination with BDG can have prognostic potential. Look at them again together, more or less. Clearly, BDG is more broad for broad range of pathogens. Galactomannan is not, but more or less they are the same. And they do have the same issues for immunocompromised patients. So we say that BDG is a pan-fungal marker, but it doesn't really cover mycomycosis, and that is a problem for many immunocompromised patients. And interestingly and quite annoyingly, it can give you a lot of false positive results in ICU. So if you use the cellulose membranes for renal replacement therapy, that affects the result. If the patient receives IVIG, it can affect the result. Tazocin, piperacillin tazobactam, might affect the result, as will maybe the use of albumin and many other conditions. So, you know, we do use it. Serial, again, so the kinetics of serial tests, but not one test is better. But again, it's not great. I'm going to come to an end, and I'm going to finish with a couple of slides that talk about the future. So this is a small study. It happened in 52 patients, single-centered, that had received stem cell transplant. And it compared C-reactive protein with calcitonin and pre-sepsin. So pre-sepsin is a soluble counterpart of CD14. And CD14 is a glycoprotein that is on the cell of macrophages and monocytes. So the whole idea about this novel sepsis biomarker is that if something stimulates your monocytes and macrophages, like sepsis, your pre-sepsin will increase, and you can diagnose and predict sepsis better. And you can see here, compared to CRP and PCT, the sensitivity is low, higher, of course, than CRP, but equally low, but the specificity is 100%. Again, maybe something in the future for immunocompromised patients. This is the other, let's say, future biomarker, the pro-adrenomedulin. So this is a precursor of adrenomedulin that is a calcitonin peptide, just like PCT, and just like PCT, release of cytokines increases it. So you see it again in this study compared to CRP and PCT, and you can see that the pro-adrenomedulin, again, in a very limited sample that we have seen, elevates faster and higher than PCT, and it will respond to treatment, and it will stay static if treatment doesn't work. Again, this is the future, because there haven't really been any studies that can establish it as something that we could use at the bedside to help us, immunocompromised or not, in ICU patients that have sepsis. So I'm going to conclude, and I'm going to conclude by saying that biomarkers are used more and more, some more than others, but to be used, they have to have a large amplitude, and they should not be fatigued. They should increase every time someone has an infection. So serial tests are definitely more than a single value, but whether you can use it to identify suitable patients for therapy and then titrate this therapy, you can't do it now. That's probably for the future. And again, I will repeat that biomarkers cannot be expected to isolatedly be the magic bullet for you to resolve your immunocompromised patient sepsis. And for this, I thank you, and I will stop sharing.
Thank you. Thank you, Dr. Victoria Metaxa. Very, very enlightening. And thank you for emphasizing on CRP and ProCal, which is available in almost all healthcare facility, even in our country. Beta-D-glucan, galactomannan, in many, it is gradually increasing the accessibility. So we already have started having questions towards you. So we'll discuss that at the end of the 3 presentation. Again, request all the participants. We have more than 100, as I can see. Please do write your questions. So for the final speaker, I would like to invite Professor Eli Azoulay, who is going to talk about the direct approach, which he has done work recently and has written on it. So we look forward to his presentation. Professor Eli, please.
Thank you very much, Audi. And I just want to say how much I'm happy to share this webinar with all of you and with my colleagues and friends from ISCCM. Very, very delighted also to do that with Professor Metaxa. I'm going to report on something which is perfectly in line with what has been said previously, which is about the clinical approach of acute respiratory failure in patients who are immunocompromised. As has been pointed recently and by the previous speakers, we know that 1/3 of ICU patients is believed to be immunocompromised, and acute respiratory failure happens in 70% of these patients. Importantly, we know that the number of patients that could be saved by a clinical approach that is really sparing exams and avoiding, I would say, complex procedures would be really able to save more than 100,000 people in Europe every year. As you all know, acute respiratory failure doesn't have a real definition, or not an operational definition. We are speaking about a patient with a respiratory distress, which by definition can only be acute, with new pulmonary infiltrates, and it is routine to consider that they are from less than 7 days, and with hypoxemia based on the need for oxygen, with usually 6 liters of oxygen per minute being the threshold for ICU admission, because it describes a group that receives intubation in 40% of the cases with a mortality of 30%. So how often do we see acute respiratory failure in patients who are immunocompromised? And as you know, immunosuppression is not something that has only one signature. You can see that in solid tumors, in solid organ transplant, in lymphoproliferative disorders, in patients with prolonged neutropenia, either from acute myeloid leukemia or from allogeneic stem cell transplantation. And overall, we can say it's 1, 10, 50. 1% is in the number in the patients having lung cancer, solid tumors, but it's more with lung cancer. 10% in patients having solid organ transplant, but it's more when it's lung transplantation. And it's about between 40 and 50% in patients with prolonged neutropenia. When we say prolonged neutropenia, we mean patients with induction chemotherapy for acute myeloid leukemia or patients having received allogeneic stem cell transplantation. In Europe, it's about 500,000 patients every year. You can see here the prevalence, the number of patients developing respiratory events according to the hematological malignancy. And you can see that acute myeloid leukemia and myelodysplastic syndromes are the two first diseases with respectively 60 and 30% of the patients developing respiratory events. If we want to improve survival, there are a number of things that we should agree on. Admitting these patients early to the ICU. But of course, it's in competition with the other patients, the number of patients having received cardiac surgery, number of patients who are sick from other disease, whether there's a pandemic, whether there's a number of bleeding patients at the maternity. But when possible, early ICU admission is associated with reduced mortality. The second one, and this is where I'm placing the direct approach, is to identify what's the cause of acute respiratory failure. 3 is the daily meeting with oncohemato. When you have such complex patients, you need to discuss on a daily basis with the oncologist, the hematologist, the transplant doctor about the goals of care, about possible diagnosis, about drug-drug interaction, and about different advances for these patients. 4 is to agree on the appropriate level of care. And the goals of care can be very different from one patient to the other, making that survival is not always the best endpoint. And last, these patients need to be cared by doctors having received a proper intensive care training. And they are board certified in intensive care, so they have done 2 years of intensive care in their curricula. And on top of that, they have some credentials and they have some trainings about intensive care. So let's focus on the cause of acute respiratory failure. You can see on this slide that overall, bacterial infection is among the top causes, followed by pneumocystis, viral infections, disease-related infiltrates. It can be the leukemia or it can be the systemic vasculitis, invasive aspergillosis, which is 7% based on how intensive we treat these patients, cardiac pulmonary edema, and a number of causes. There are 2 things that I want to point out in this slide. The first one is 15 to 20% of the patients are left with no cause identified. And it is a problem because these patients have a double, if not 3 times mortality as compared to patients with a diagnosis. And the second point about this slide is that I don't like this slide. Because this slide gives you the feeling that everyone can have aspergillosis or pneumocystis, which is absolutely wrong. So by giving you the feeling that everyone can have anything, this slide is misleading. So this is why we are having a clinical approach that directs the patients more into specific conditions. I want to emphasize also that we are capable to define the complications. We know how to define a pneumocystis, a viral infection, an aspergillosis, or a bacterial infection using the definitions that have been released in the literature at many places. And when with Victoria and our group, we prepared this paper, we were very happy to see that almost all the definitions are in the literature. For example, you can define aspergillosis, mucoral, pneumocystis, cryptococcus, coccidioidomyces, blastomyces. Every disease has a very specific definition. Some of you were maybe thinking that I was about to speak about oxygenation strategy in this patient. But I'm not going to do that, because if you compare standard oxygen, high flow oxygen, or early intubation in the setting of immunocompromised patients, there is no evidence that there is a difference. Some would say that early intubation might be protective in patients with high respiratory drive, having a self-inflicted lung injury, because they receive by themselves, they receive 12, 15, and even 20 milliliter per kilo of tidal volume. Of course, this is not something you would have prescribed, but this is the respiratory drive. In the current literature in immunocompromised, there is no demonstration that any of these strategies provide any benefit. All of these treatments are equal. Of course, there is a trend for reduced intubation using high flow oxygen, because high flow oxygen is the only one capable to deliver a flow that surpasses patient's drive. So by doing so, it's going to calm down respiratory rate and deliver a more stable, a more constant FiO2. But in terms of survival, there is no demonstrated benefit. If I want to focus on the acute respiratory failure etiology, on the causes, I want you to accept that I cannot do that using only one system. If I do only chest X-ray, I would not make it. If I'm speaking only on underlying malignancy, you can see here myeloma, CLL, ALL, lymphoma, T-cell lymphoma, DBLCL, diffuse B large cell lymphoma, it will not be easy. If you are using only the treatments, it's not going to be easy. It's a combo of everything. You need to understand what makes the diagnosis by knowing what are the determinants of acute respiratory failure etiology. So we have 3 steps. The first step is the GPS. The GPS is the direct approach. It is a way for you to assess pre-test probability. So before you even do a blood culture, you would have in mind that this patient might have a bacterial infection, an aspergillosis, a pneumocystis, or maybe a drug-related pulmonary toxicity. Then, based on the GPS, you're going to decide not only the first-line therapy, but also the appropriate tests to confirm the diagnosis. And then you will make the diagnosis using some exams on these tests. You can do, for example, the same exams on BAL, nasopharyngeal aspirates, nasal swab, or sometime an induced sputa, but of course, it's not going to have the same sensitivity. So 1, the GPS, 2, what is the diagnostic test that you're going to make, and then what is your diagnostic strategy. So this is the direct approach. The direct approach was published something like 20 years ago, and we described DIRECT for direct, the time since the malignancy or the immunosuppression has started, the type of immune deficiency, because if you have a pneumocystis pneumonia, by definition, you have a T-cell defect. So if I receive a patient with a diffuse B-cell lymphoma or an ALL-B, I'm not going to start a treatment for pneumocystis. And if I have an AML patient, I would wait for 7 days before thinking on the risk of aspergillosis, etc. Then we have the chest X-ray and the CT scan that are providing patterns very likely to mimic a typical diagnosis. Then we have the clinical experience. We are here ICU specialists, so we know that if a patient has a shock, a septic shock, so then the bug must be a bacteria. And then there is the clinical picture, because sometimes it's very important to see extrathoracic signs. And if you have a skin eruption, or if you have a bone involvement, or if you have a CNS involvement, so then you would think to something else. So the direct is since when the patient has the disease, has received transplant, has the prophylaxis or the treatment, what's the type of cell mostly involved in the immune deficiency? Is it the neutrophil, the macrophages? Is it the monocyte? Is it sometimes it can be a humoral immune system? How is the chest X-ray and the CT? How are the discussions that you are sharing during the multidisciplinary round? Yourself inside the ICU team and with oncologists and hematologists? What are the clinical findings and how is the CT? So this is the DIRECT, the direct approach. So these are different cases where I'm using the direct approach. I know what is the underlying disease, what's the type of immune deficiency, what are the clinical signs, how is the chest X-ray, how is the CT, what are the results of the direct approach, so what are the pre-test diagnoses, what I'm going to do as a test, what will be my strategy leading to a definite diagnosis, and then I will speak about outcomes. And here you have different cases. So you can see here a patient with AML, age 44. So we know that the patient has cough and dyspnea since 3 weeks, and that the patient has never received any treatment. So I'm thinking on a viral infection or an alveolar proteinosis, because in AML, the myeloid contingent is able to make the surfactant immature and have an accumulation of protein material inside the alveoli. So I'm going to do a bronchoscopy and BL first line, because it's the only way to evaluate alveolar proteinosis, and then I will make the diagnosis and start treating the underlying malignancy, because only chemotherapy will be able to control the disease. I'm taking here another example in a patient with AML. So you can see that we have different phases: the diagnosis, the treatment, and 1 to 2 weeks after the disease onset. So before any treatment, the patient might come, you see here in red or in blue. Red is myeloid, blue is lymphoid. You can see that in red, in acute myeloid leukemia, we mostly have leukemic infiltrates that can be either infiltration or leukostasis. And when it's in blue, patients have ALL. So it's mostly about infection. It can be flu, it can be COVID, it can be Legionella, it can be pneumocystis if it's a T-cell defect. Because we know that when we have a T-cell defect, even without any treatment, we can have pneumocystis. When we start treating, we have the drug-related cardiac or pulmonary toxicity, but we also have in AML the lysis pneumopathy. It always happens with a tumor lysis syndrome, and the lungs are bleeding, and it takes a certain time. 80% of the patients are intubated, and mortality can be high because it takes no less than 5 to 7 days for the patient to improve. In blue, still we are in infections, whether pneumococcus, whether drug-related pulmonary toxicity. And then when you enter in the tunnel of neutropenia, you can see aspergillosis, you can see invasive viral infections, mucoral, and other diseases like CMV. And then during consolidations, you accumulate not only the risk for disease-related infiltrates, but also the deepness of the immunosuppression, taking you to tuberculosis, geotrichum, nocardia, fusarium, and all of these very severe infections. Leukemic infiltrates are always when there is leukemia at the beginning of the diagnosis, at the diagnosis onset, because we need circulating blast cells to have leukemic infiltrates. If you have a lot of cells, it will be a leukostasis. If you have a number of cells that is quite low, but you have leukemic infiltrates, this happens usually in monoblastic AML, and it is usually less severe because when you start chemotherapy, you have the patients are weaned from oxygen. When there is leukostasis, it's very different. Leukostasis requires at least 50,000 blast cells, but is constant when there are more than 200 blast cells. And usually the risk is that you are going to have a burden of leukemic cells in the pulmonary vasculature and to create a lysis pneumopathy. So these are the three types of leukemic infiltrates. You can see that we can compare the three different features, lysis, leukemic infiltrates, and leukostasis, and the three are very, very different. Here on the left, you can see leukostasis. In the skin, you have hematodermia. In the gingiva, it's full of blast cells, and some patients are sent by the dentist. And here in the patients who died for myocardial infarction, you can see how much busy are the vessels, the coronary vessels, full of a huge number of leukemic cells. This is called cellular hyperviscosity. Very different in infiltrates with low number of cells, which is called leukemic infiltration, where we only have the veins and the lymph vessels that are full of blast cells. And in the part in the right side, we need to start chemotherapy. In the left side, we need to reduce very, very slowly the number of leukemic cells. So we do hyperhydration by 30 milliliter per kilo of saline. And then we are going to use hydroxyurea to make the cells go down to 50,000 very slowly. And then we will start chemotherapy. Because otherwise, we will create lysis pneumopathy and the patients will get intubated. So the eye of the direct is always to understand what type of immunosuppression you are facing. Neutrophils, macrophages, B cells, T cells, antibodies, and it can be either from the disease that itself creates immunosuppression or from the treatments. And for every single cell, you will have the probability of having a certain type of infection. This is why I'm saying that the T cell defect is the one where I'm really thinking on Aspergillus, CMV, and pneumocystis. We are using a lot the CT scan. The CT scan explores the space between the alveoli, here in green, and the vessel. And this space is characteristic when we have an infiltration by either the cells or the bugs. So we are going to look at it, really paying attention to whether we have central-lobular nodules, septal lines, or sometimes ground glass opacities. Klaus Heusel was the first one in 1999 to explore CT in patients who are immunocompromised with acute respiratory failure. And this is what you need to look at, whether there are ground glass opacities, which means alveolitis, consolidations, which can be bacterial or fungal, nodules, but then you need to know whether the nodules are in the center of the lobule, which is bronchiolitis, or subpleural space, which means that there is a septicemia, bacteremia, or whether they are around the lymph vessels. The linear opacities, where there are the veins, where can circulate water and salt, if it's a pulmonary edema, or blast cells or tumoral cells, when there is leukemic infiltrates or lymphangitis. We can have cavitations when it is about tuberculosis or nocardia or aspergillus or sometimes pleural effusions. So this is why for every disease you need to describe what is the most important pattern, and then for every pattern we have a type of test to start with, and then also a probability of disease that we need to treat first line. It's very important to treat first line to avoid delaying effective therapy. This is a 34-year-old man with a T-cell leukemia. He has never received any treatment. The disease is subacute since 11 days with deep hypoxemia, 30 on room air, and the patient really looks like an HIV patient with a pneumocystis pneumonia. It's true, it is a pneumocystis pneumonia, HIV is negative, and it shows you that when you have a T-cell leukemia, you can develop a complication related to T-cell defect. Look at this publication with 214 pulmonary cases of pneumocystis, and 3% of them, 30 patients, had never received any treatment, really showing how much important can be the immunosuppression from the underlying malignancy. When you combine in the direct the D and the I, you can see, for example, when you have a hairy cell leukemia at day 0, we need from the I that the hairy cell leukemia has a specific defect against intracellular bugs. Then, instead of doing a bronchoscopy, you're going to do either a urine antigen or a PCR on a swab to diagnose Legionella, because this is a mandatory intracellular bug. If we are at day 15 and the patient had nothing at day 0, the patient being treated with the 2-CDA that is very effective in HCl, you would need to think on drug-related pulmonary toxicity. So here, bronchoscopy and BL are mandatory. So the patient is going to be intubated for bronchoscopy and BL, and you will find that it is full of eosinophils showing the drug-related pulmonary toxicity. And after 4 days of mechanical ventilation with pulse steroids, the patient was extubated, even if he was on prone positioning at day 1. I'm passing on that just to show you that every disease can have a name, like aspergillosis, but has different clinical presentation. On the right, you have those patients with aspergillosis that you can see during neutropenia with the halo sign that is really like a pulmonary infarct from granulomatous aspergillosis. However, on the left side, you will see an airway invasive aspergillosis that we can see like in lung transplant patient, but also in allogenic stem cell transplant patient. And you can see that it is also an invasion, but here it's of the respiratory tract. And the disease are very different, carry different outcomes, and certainly should have different treatments. Again, when you speak about the patients with hematological oncology transplant with a specific acute respiratory failure, you need to describe it by providing the different component of the direct approach. It makes it very easy, it eases the diagnostic strategy, and it helps you give within 1 to 2 hours the appropriate therapy. All of this because it's not so easy to use bronchoscopy and BAL in these hypoxemic patients because they are at high risk of getting intubated after the procedure, and we need to avoid intubation when it's possible. And we know that in our group, we even published a paper comparing patients undergoing bronchoscopy and other patients, and there was an increased mortality in patients undergoing bronchoscopy because of the deep hypoxemia, the number of patients deteriorating after BAL, and all the consequences of this procedure in these very fragile patients. Again, we can easily manage these patients without bronchoscopy and BAL, but sometimes it is very useful to do it. So this is why a more personalized approach like the direct one will allow you to use the strategy in specific situations. Like, for example, when we want to diagnose disease pulmonary infiltrate or drug-related pulmonary toxicity, BAL is still useful, and we consider that about 20% of the patients need to receive a BAL, to undergo a BAL, and this is why we do it when it's needed. So this is my last slide. If you want to know more about all of this, you're welcome to the BDI that is every year in January in Paris, and every year we received a lot of delegates and colleagues from India, and we would be very happy to welcome you. Thank you very much for your attention.
Thank you, Professor. And very nice to hear from you regarding the direct approach, a very practical overview. So we have now about 15 minutes where we can discuss. Let me go to the chat box. There are a few questions related to use of diagnostics. Use of Procal in starting antimicrobial. We all know about Procal as regards to de-escalation and stopping. So Dr. Victoria, since you have taken up the diagnostics, Procal has never been suggested to start antibiotics. So how do we address this situation? Especially in compromise where CRP is probably not very specific.
So yes, I saw that. I saw that question. It's a very, very good question, and I think the answer is unfortunately you can't. And I think that's a very, very clear message from all literature. You can't really use CRP or PCT just as a number, just as a test to just start antibiotics. You can't. It feeds. It's a post-probability test. It feeds into the pre-probability, which means that you have to think, you have to suspect that your patient has sepsis. You have not just inflammation, not just the tumor that's getting worse. And then the PCT will confirm that. So the PCT will fit nicely into an algorithm where clinical suspicion is the first thing.
So it's like a piece of a puzzle, sort of. You have to make a picture. So I think it's not, as Dr. Victoria mentioned, can't be taken in isolation. So let me just ask the panel, anyone, PCT has a very good negative predictive value for fungemia in the sense that we have a lot of dilemma when we are not very sure in sepsis syndrome, whether it is bacteremia or is it candidemia in immunocompromised. So what is the approach? In our country, a fever not responding to broad spectrum, where in the West, the broad spectrum could be carbapenem, and patient not responding, you start thinking of fungus. But we have a lot of resistant organism, carba-resistant organism. So fever not responding to carbapenem could be a carba-resistant bacteria or could be a fungus. So let me ask Dr. Subra. Subra, so in a sepsis syndrome, in an immunocompromised, how do you handle this when you have a dilemma between bacteremia and fungemia?
So when we're thinking of pulmonary pathogens, it all depends on the setting as well. So if it's a community setting, even in patients who are profoundly immunosuppressed, the risk of a carbapenem-resistant pathogen is fairly low. So that's the really good news. But unfortunately, you have to start worrying about whether Staph aureus is a possibility, whether you could be colonized with Pseudomonas if you have underlying lung disease, certain unusual pathogens. Obviously, in our community, we have lots of people who are heavily antibiotic experienced. And there lies the problem with regards to multi-drug resistance, including carbapenem resistance. So we do see weird stuff at least once in a while. But on a daily basis, should we worry about carbapenem resistance when a patient comes in right off the gate? Right out the gate? The answer is probably no. I wouldn't cover for a carbapenem resistant pathogen upfront unless I have history that the patient has been recently in and out of hospital settings and patient is likely to be colonized with a carbapenem resistant enterobacterial or something like that. Now, the bigger issue is about use of procal. While a negative, see, the question of what is a negative procal itself is a bit of a mystery to me. I agree with what has been said that the dynamics make a lot more sense than an individual number. The problem is we don't know any person's procal in their natural state. So if your normal procal is 0.01, a procal of 0.1 is 10 times elevated, which is actually quite damn high. But on the other hand, if your normal procal is about 0.08, and if it's come up to 0.1, it probably is not a big deal. And unfortunately, when we don't know what the normal procal is, and we are trying to make guesses based on a singleton number, it becomes a bit of a problem. I understand the feeling that if you have a low procal, you have to consider the possibility of fungal infections. But there are also other non-infectious mimics as well, like cardiac failure and all that, which will come into it. It's not just fungus. And the problem is you are hoping that a fungus will exist in isolation or as a singleton. In a profoundly immunosuppressed patient, like a neutropenic patient, like a stem cell transplant recipient, Occam's razor need not apply. And there you may get fooled into a lull, into a sense of complacency, thinking this is all there is. And therefore, it's a little complicated. But yeah, all of us do this. When we see a kind of a lowish procal in the setting, we start thinking about a fungal infection. I think that's reasonable, but we can't put a hat on it and say, that's the reason why I think it's a fungal infection.
It's not that specific. So again, I think one has to look into the entire picture. So coming to Dr. Eli, there is a question about multiplex PCR. In your direct approach, where do you put the biomarkers, the multiplex PCR diagnostics? And in which part of this algorithm do they come?
So personally, I never use any biomarker. I never use PCT, I never use CRP, I never use BNP. Of course, I might use them in specific cases, but it's not routine at all. The most important thing, even for blood culture or for any diagnostic test, is to start thinking on the patient and have a pre-test probability for every diagnostic. So PCR would happen when I really consider that I have the possibility of identifying a viral infection, because being able to identify a viral infection allows you to de-escalate regarding other antifungals and other drugs, and sometimes to avoid making a bronchoscopy and BL. If you are using PCR panels for bacteria, I must say that we are currently making a proper evaluation for that, for BioFire and other PCR techniques. So I'm not able to provide you with real data. I can tell you that it's very sensitive and very specific, but we are still using it. So I will use that also for intracellular pathogens like Legionella and Chlamydia, because we have seen so much in 24 of these two bugs that we have been really introducing that in routine. So PCR and multiplex PCR is for viral infection, for intracellular pathogens, and if you are into using it for bacteria, I'm not able to give you now the results of the ongoing studies.
Yeah, especially for the mycoplasma as well, for the multiplex PCR. And the multiplex PCR in nosocomial setting with bacteria, we get so many bacteria as positive. When we ET suction, you never know which one is the pathogen. And we get so many of resistant organisms. So it might be that it might have some negative predictive value, that if I'm not having an Acinetobacter PCR positive, then I do not need to cover for that bacteria. Do you think that might be one of the ways to look at it?
So we do that a lot for Pseudomonas. To be honest, when patients don't have a structural lung disease, we want to be sparing about anti-Pseudomonas agents, and we would start a regimen that doesn't cover Pseudomonas. We are not having the same rates and the same prevalence of multi-resistant bacteria, but we are having some, of course, and we would use also this test to assess microbial sensitivity when there is a pathogen who can be multi-drug resistant. When there is no structural lung disease and we are in oncology, I would recommend using third regimen cephalosporins, because we still have an indication for that when patients have been little exposed to antibiotics and to hospitalization. When there is a structural lung disease, when patients have COPD or lung fibrosis or anything, so then we need to really to consider those pathogens, including their resistance.
Thank you. There is a question on how to diagnose pneumocystis, especially if you are not doing a bronchoscopy. So
today, bronchoscopy is not mandatory anymore for pneumocystis. So let me go to the basics. For pneumocystis, you know that pneumocystis cannot be cultured. So you need to identify pneumocystis either using coloring methods or using PCR. Coloring methods include either induce sputa, and then you centrifugate and you look at the cells. In HIV patients, where it's full of pneumocystis, you can see only on the cells that there are trophozoites of pneumocystis in HIV patients. In immunocompromised patients who are not HIV, because there is a huge inflammatory response to pneumocystis before pneumocystis can develop, the number of cysts is very reduced and the number of cells is very high. So this is why we need to go to coloring. Coloring can be toluidine blue, can be Gomori Grocott to identify pneumocystis itself. And there is, at some places, an antibody that can help to do immunofluorescence that identify both cysts and trophozoites. But all of this is not done anymore in many European labs because it takes time, because there is the need for high volume, and because people are looking forward to avoid recruiting people. So PCR is then now the method of reference. PCR is very effective in BL, is very effective in induced sputa, and in our data, of course, depending on the threshold, it's also very effective in nasopharyngeal swab. So today, we only use PCR. Then comes the question on whether it's a colonization or an infection. Again, I'm always thinking before I'm testing. So if I have a high probability of pneumocystis, I would choose the diagnostic test to confirm the disease. So this is where I would do a BAL, I would do an induced sputa with PCR. If I'm with a very low probability of pneumocystis, I need to rule out the disease. My clinical question is very different. So then I would do beta-D-glucan, which has a very high, as shown by Victoria, a very high negative predictive value. And if it's below 80 picogram per milliliter, I would rule out pneumocystis pneumonia.
Good. That's a very good practical approach. We have Dr. Pradeep, Dr. Srinivas, Dr. Bharat. Do you have any final queries for the panelists? Because we're coming to the end of our discussion. Dr. Srinivas, Dr. Pradeep, Dr. Bharat.
I think there was one more query, sir, about how to differentiate between colonizers and pathogens in the immunocompromised. But how do we go about it, especially when you use a lot of molecular diagnostics and you get a lot of noise in the results? How do you, sort them out and say this is a pathogen and this is not a pathogen?
Anyone?
This is where the biomarkers take all their effect. Because the question is, there are three answers. One answer is when you don't think on a disease, you don't take into account the result. So you can provide me with any aspergillus coming from anywhere. If I'm not thinking on aspergillosis, you will keep it in your file and I will never treat the patient. There is another approach using biomarkers. And galactomannan and beta-diglucan, as shown by Victoria, has been very much validated in that sense. We can give it to Victoria later. But there is another approach that is currently ongoing and takes a lot of place, is to use the markers of host response by transcriptomic. Looking at the RNA and looking at the omic strategy that would allow you to a specific disease. For example, in pneumocystis, you would rely on whether host response has been targeted by pneumocystis. If yes, then it's pneumocystosis. Otherwise, it is a colonization. We are currently working on that by customizing the clinical scores by beta-diglucan and by transcriptomic data. I don't have the results.
Okay. So, Srinivas, any concluding remarks before we close?
I think it's been a fantastic program and fantastic evening. Thank you, Dr. Swaminathan, Dr. Daxa, and Professor Azule. I think it was a great learning experience, and I think we're still evolving as we adapt biomarkers and molecular diagnostics. But as has been emphasized, it is a combination of clinical judgment, pre-test possibility, and a judicious application of the tools we have, which will help us in sorting out the diagnostic dilemmas in immunocompromised patients. Thank you all. Thank you, sir, for moderating this session. It's been a fantastic learning experience for all of us.
Thank you.
Thank you all, and it was a pleasure to be with all of you. And we look forward to the next opportunities. Have a great day. Have a great evening.